right now, I really want to take 2 seconds to tell you, I did nothing to prepare for this. I have a superpower team that has done literally all the work for this event. That is Ellen Encisco and Brittany Levy and Julie Ludwig and Isla Senjic have done all the work for this event, and I want to thank all of them because I do nothing. Especially Ellen, I don't think has slept in the last few weeks because she's done everything. Finally, she's keeping me organized. All right, we're going to get started. Any questions or comments that I did not mention? Ellen, did I say everything? All right, so we're going to get started with our first session. Why don't you guys go up there. So this first session is, as we did it the last couple of years, we review, I'm sure everyone saw last year's event, but just in case, we're going to review the top critical points that were discussed over the last year by this team. Cecilia Gigena, we have Brittany Levy and Ellen Encisco are going to introduce what happened last year. So guys, take it away.
Thank you. So as Todd said, we're just going to review the last year. So we'll review last year's update course a whole year ago. I know some of you are repeat visitors. And then we'll talk about an event we had back in April, the best of the best in pediatric surgery. And then we'll talk about the program we have coming up for you. Can I grab the clicker? I'm sorry.
Oh, yeah.
Right there.
Here it is.
Thank you. Okay.
Top button's the spotlight thing.
Yep. So as I said, we'll review last year's Pediatric Surgery Update Course. And so we thought it'd be interesting to review some of the questions that we had last year and do kind of a post-test and see if we changed our answers, if we changed our practices in any way. Some of these questions don't necessarily have a right answer or a wrong answer, but we'll just see how things change compared to how we all answered last year. So the first question, we have a 10-year-old child brought in after a motor vehicle accident. He's noted to be hypotensive. He receives a 20 cc per kilo normal saline bolus, but remains tachycardic and hypotensive. Isla, if you could put up the poll question when you're ready. And so what is the next best fluid for resuscitation of this injured child? Do we give another bolus of crystalloid? Do we begin maintenance fluids? Do we transfuse with 20 cc per kilo of packed red cells, give cryo, or no further fluids at this time? You should see the poll question coming up to the right on your screen.
Didn't come up yet, so we'll just keep going. Sorry.
We'll just keep going.
Yeah.
When we have it up there, you can participate, answer the question. Todd, what do you think? Do you think we'll answer differently?
I'm hoping that a lot of people saw our event last year. I know I changed, so let's see if, I guess we won't know, but I'm hoping most people will get this one right.
All right, as soon as Isla gets it up, we will answer the question. What about anyone else? Anyone else do you think we'll answer differently or change our practice? That's okay. We can, what answer would everyone say here? C.
C.
Perfect. So we answered this way. Eventually we could check and see how the rates last year. Over 50% said C, but some people were still saying A, give another bolus of normal saline. So from Dr. Rika last year during the APSA PDC updates, we heard about the new ATLS guidelines talking about transfusing earlier rather than giving 2 boluses of normal saline. We'd also talked a little bit about whole blood therapy. If you want to hear the whole talk or some of our summaries of the talk, they'll be online. They are online or on the app, so you can always watch again. We can go ahead and go to the next question. So this one was from the course on pectus updates. So here we had a otherwise healthy 16-year-old with shortness of breath on exertion and a pectus index of 5.5. He's planned to undergo a NES repair in addition to multimodal pain medication. What do you recommend for perioperative pain control? Would you use cryoanalgesia, paravertebral indwelling catheters, thoracic epidural catheters, paravertebral blocks, or no additional modality? The poll's up now?
Yeah.
Okay.
You guys seen the polls? Yeah. No. So it might be try to refresh.
We're getting the polls up, it sounds like.
Audiences, so something is about us, so don't worry.
Hey, Todd, can I ask a question?
Go ahead.
So I think this is sort of institution specific because some places don't do cryoanalgesia and some places don't do some of the other things.
Yeah.
Right.
So I think all of you. Yeah. So
You're right.
Yeah.
You're right.
So I was just saying that I think that the answer to this question is institution specific. And I think the literature supports several of these, and individual surgeons may support one option over another.
Definitely. Yeah, we were going to see, how if more people are doing one thing or the other compared to last year. Like, I agree that it's institution specific.
Okay, we'll try and see if this mic works. Guys, we're going to switch everyone here to the regular page. That's the one that's working. The chat one's not. So we'll switch. And it's going to come around.
And Ellen, the only thing I would add is that not only is it institution specific, but it's probably patient specific. That is, some patients, and offered the opportunity, for example, of cryoablation, will say, no thanks, doc, and we'd like to go with something else. So there is certainly some variability.
That's a good point. Do we have some results that tied? Okay. Well, last year, more people were saying C. So I guess some more people, we talked a lot about cryoanalgesia last year, and so it sounds like more people are starting to do it, but I agree it's still institution and patient specific. Again, we had a whole session on pectus last year, the whole talk, and our summary of the talk is online if you want to review it. Any other thoughts from the audience? Awesome. So the next question is from our DEI session last year from Dr. Kodagal. So we have a 14-year-old black male presenting with abdominal pain. His workup included a history, a white count, and an ultrasound, which were consistent with appendicitis, most likely perforated. He and his mother, who is with him, report that this is their third visit to the ED in a row over the past 7 days for abdominal pain. What do you think his delay in diagnosis is due to? So either biologic factors causing a difference in his presentation, implicit bias amongst the providers caring for him, a delay in presentation by the patient and family, or all of the above. And I think, is the poll, do we have the third poll up? I think it's up, so we can answer. Okay. Awesome. What do you think, Dr. Kodagal, do you think people will answer differently?
I hope so. There did definitely seem to be a lot of recognition around implicit bias and that
Yeah.
broadening discussion around the fact that we all have biases that we don't necessarily know about
Right.
and not intentional.
Right.
They're very subconscious.
We'll see.
Let's throw the poll up there. It looks like
Implicit bias, 50% right now.
50% for implicit bias. Let's see. Last year, it was about a little over 30%. So it sounds like more people learned from your session. And I think we'll hear more about this later this morning, actually. So we'll talk more about diversity, equity, and inclusion later this morning, and implicit bias. These are just some slides from Dr. Kodagal's presentation last year, like she said, recognizing biases and recognizing that they can have an impact on outcomes in healthcare. Again, you can watch the whole thing online, and we'll talk more about it later this morning. Okay, fourth question, we have 2 more to go. So here we have a 1-day-old female brought in at 39, or was born at 39 weeks gestational age, 2.5 kilos, has a short perineal body with an anal opening anterior to the muscle complex and posterior to the labial folds. The anal opening size is a Hagar 6 dilator. Factoral workup reveals a PDA with left to right flow, moderate hydronephrosis on the right, and a conus at L1. So do you discharge them home with dilations, divert with a colostomy and mucous fistula, or go ahead with your PSARP? And the fourth poll should be showing up. Correct.
starting, it's going. People are answering.
Okay.
It's moving like crazy.
Perfect. And this was from the session we had last year from the updates from the PCPLC. With Dr. Rentia and Dr. Smith, who unfortunately couldn't be here this year, but we'll see if anyone changed their
So I'll
answer.
tell you, so far, it looks like, what percent, it's moving like a ton, but it's like 57% discharge home with dilations.
50% discharge home with dilation.
But
Let's see.
PSARP is catching up.
Okay. We'll see. So it looks like you said 50, so maybe more people are saying PSARP this year than last year. So last year we talked about a number of different topics from the PCPLC, but they did share a couple of different studies about similar outcomes with doing some of these procedures early versus late. So there was one about doing a pull-through for Hirschsprung disease, and then another about doing the PSARP early versus late and how they showed similar outcomes. So some people may be doing the PSARP or the pull-through earlier. Again, this is all online if you would like to review.
Ellen, there's a chunk there talking about philosophies and meeting specialists, and I think a lot of that is about location and resource limitations. So in much of the world, the resource limitations, everybody with an aortic confirmation gets diverted.
Sure.
And so I think recognizing that some of that is about context and what resources are available.
Good point. Thank you. Okay, and our last question from last year. So in this case, we have a 12-year-old boy, 70 kilos. He presents with several episodes of right upper quadrant pain and is found to have cholelithiasis. So what do you do for workup and management? Do you go ahead with the ultrasound and medical therapy, a pre-op ultrasound and laparotomy, pre-op cholangio MRI with laparoscopy, pre-op ultrasound with standard laparoscopy, or do you do the pre-op ultrasound laparoscopy using ICG? So this one was from our session on ICG with Dr. Chiro Esposito. And so we'll see if people answer differently, like I said, compared to last year. Do we have people answering yet?
Standard laparoscopy.
Winning. Okay. So this is pretty similar from last year. I think that we've talked a lot about ICG at various places like here. We talked about it at IPEC some more. So maybe more people answering ICE at all.
SCG's trying to come back.
Yeah. Well, maybe more people are picking it up. Fair enough.
Doing standard laparoscopy and
Yeah, that's
one
true.
part of the people doing ICG.
That's true. You can't just decide to do it. You have to get the equipment and everything. Sure. Yeah. Do you have the mic in?
So just yesterday in Buffalo, we had this exact scenario, and there was an accessory cystic duct that only showed up clearly because of the ICG. So just advocating.
Yeah, very useful then. Perfect. So like I said, Dr. Esposito last year talked all about ICG and the several indications. I know the cholecystectomy is a pretty common one that people use it for. And like Dr. Imeski pointed out, you need the special equipment and everything. But there are other uses for it: partial nephrectomies, varicoceles, lymphomas, tumors, and I'm sure the list goes on. But we have this talk online from Dr. Esposito from last year if you'd like to review it. So those are all the questions we had from last year. Just a general question for our curiosity. Did you change any of your practices based on what we talked about last year if you attended last year or watched? And so you can go ahead and answer that. And while you all are answering that poll, I will hand it over to Cecilia for the next segment.
Thank you. Okay, hello everyone. Thank you, Ellen. Well, I don't know if everyone saw it, but we have an event this year that was the best of the best in pediatric surgery 2021 recap. That was held on April 8th, and we have 5 societies that you can see below in this slide that we have APSA, CAPS, UPSA, IPEG, and the Pacific Association. So everyone was here. We have the boat, and we have 15 presentations, and attendees were 680, and we have everything in our app. So if you want to see it or re-see it, we have a lot of more attendees for that. So the winner of all was CAPS and this administration of amniotic fluid stem cells, extracellular vesicles, and it was really interesting, and the idea is to have everything. We know that we can't go to every meeting in the year because of personal things or because we have to travel, and also we have to work and have our patients. So the idea of this event is to gather everyone's in societies and everyone's here, the best of the best, and to find out what's new in every part in the world. So if you really like this, you can say if you want us to do it for 2022. And also, please, if you want this to happen and if you want us to add another society, type in the chat what society you would like to see this year. And we are very welcome to receive that. So now it's Brittany.
Awesome. So it was so great to review everything that we've done over the last year. We're so glad that you all tuned in to the events that you did, and hope that you will tune in to all the events this upcoming year. So now to start off this academic year, we've have our update course, which we're also glad that you're attending either in person or around the world virtually. And so we wanted to describe to you how we chose the agenda for this course. And so we thought, how do we know what the biggest updates were over the past 12 months? And so we asked, well, what have we implemented in our hospital systems, either nationwide or worldwide? And so we asked you all. We asked out on social media, we asked these people in this room, we said, what have you been doing differently in your clinical life, either just in your own healthcare system or you've heard about around the world? And through that, we identified different hospital guidelines and protocol changes, evidence-based changes that have been implemented, and we chose some of our topics. Then we thought, well, what goes into creating hospital guidelines? Well, it's top articles, and so we identified the top articles in both pediatric surgery core journals and other journals that have come out in the past 12 months. Well, there's also a lot of hot topics that go on in pediatric surgery, both in advocacy, politically, and just new and exciting technologies that come up across the year, and so those are how we chose the final topics, just to add a little bit of interest to today's agenda. And so we're so glad that you're all here. We're going to talk about all of these topics today with experts from around the country and around the world, and we're excited to get started.
I want to make a comment. This was Brittany's brilliant idea of, because we always say, how do we pick the best? It's been kind of random. It's been honestly us saying, that's cool. There's got to be a better way than that. Brittany had this idea of asking hospitals what actually changed. That's how we know they felt it was impactful. However, please tell us if there's a better way to do this. We have to get better at choosing what's best, what's important, what you need to know. So we would love anyone's feedback either now or in the future. We're short on time now, but text me, email me, let me know if there's a better way.
Absolutely. So we'll be right back after a short break with our first presentation of the agenda.
Wow, we finished with 3 minutes to go. Any questions or anything on this? Because we've never finished early before, not used to that. The other thing we've done to get find out what's best is we've been asking the journal editorial boards, what do you think is the best article that's come out? You'll hear next about another very interesting way that we find out what's new and important. That's Jose Campos, who's going to talk to us about another very interesting way of figuring out what's new and important. And Craig and Chuck and PJ and Mary Edwards will talk about APSA's approach to determining what's best. We're all kind of coming together to say there's too much information. Let's figure out how to filter. So if there's no other comments or questions, we'll go to break. All right.